So hello everyone and welcome to the case 35 of this case discussion series, and today we'll be discussing a very simple case. It's actually a spotter case. So here we have a 26-year-old male who came with backache since the past 6 months now, and this is the MRI done for this patient, MRI dorsal-lumbar spine. Clinically, the first thing that we suspect in a young patient with chronic back pain is ankylosing spondylitis, and on MRI also this was the picture that was seen, that the anterosuperior ends of the vertebrae showed hyperintensity in the dorsolumbar spine, as well as the discovertebral areas showed hyperintensities on T2 weighted images. On stir images also it showed hyperintensity confirming active inflammation. These areas are called Romanus lesions, anterosuperior corner, and this discovertebral lesions are called Anderson's lesions, that is non-infective spondylodiscitis. These are the T1 weighted images where there is mixed signal intensity. These are again the T2 weighted images where we can see that the dorsolumbar spine is predominantly involved. The cervical spine is typically spared. I got a screening done for the sacroiliac joints as well, where we can see on the stir images there is hyperintensity on the iliac side in the lower two-thirds of the joint, suggesting marrow edema. And on T2 weighted images there was some hypointensity also that was seen, indicating sclerosis. So this is the report I had given, that there is central abnormal discovertebral signal affecting both halves of the vertebrae of multiple vertebrae in almost hemispherical shape, and the end plate lesions appeared hyperintense on T2 and stir and hypointense on T1 weighted images, which was suggestive of rheumatic spondylodiscitis or non-infective spondylodiscitis or Anderson's lesions. Then there was signal changes, that is hyperintense on T1 as well as T2 weighted images in the anterosuperior corners of multiple vertebrae adjacent to the end plates, uh, particularly involving the dorsal and the lumbar spine, which was suggestive of shiny corner sign, that is because of the erosions, active inflammation, enthesitis of the anterosuperior ends of the vertebrae, which is in contact with the annulus. It's called shiny corner sign or Romanus lesions. Then in the screening of the hip joints, bilateral sacroiliac joints showed symmetric subchondral bone marrow edema, typically affecting the iliac end in the lower two-thirds of the joint. This sacroiliac joint, upper one-third and lower two-third. Lower two-third joint is basically synovial joint, which is actually involved early in case of ankylosing spondylitis. And in this case, the lower two-third of the joint was typically involved, and the antero-inferior aspect of the joint was actually involved, which is actually involved in the early stages. And the iliac end is typically affected first because of the thin cartilage there as compared to the sacral end. The features were suggestive of ankylosing spondylitis, a typical case of ankylosing spondylitis. So there's a diagnostic criteria for the diagnosis of ankylosing spondylitis or axial spondyloarthritis, that is called the ASAS classification criteria, in which the patient should be having backache for more than equal to 3 months and the age of onset should be less than 45 years, which was present in our case, the 26-year-old male, and he was having backache for 6 months. 6 months now. So the criteria says that the sacroiliitis should be present on imaging, which can be diagnosed on X-ray as well as on MRI. On MRI, there will be active inflammation, which was seen on stir images, highly suggestive of sacroiliitis, or there should be definite radiographic signs according to the modified New York criteria. So sacroiliitis was present on imaging. Along with that, any one of the spondyloarthrotic features should be present, which includes inflammatory backache, arthritis, enthesitis, uveitis, dactylitis, psoriasis, Crohn's or colitis, good response to NSAIDs, and this patient was having very good response to NSAIDs, family history of spondyloarthritis, HLA-B27 and elevated CRP. Or if HLA-B27 is positive, then any two of the spondyloarthritic features should be present of these. So this is the diagnostic criteria. So coming to the imaging findings of spine which are seen in ankylosing spondylitis. In early case of spondylitis, it is characterized by small erosions of the corners of the vertebral bodies with reactive sclerosis, which is called shiny corner sign or Romanus lesions, which were seen in multiple vertebrae of the dorsal and the lumbar spine in our case. Squaring of the vertebra, that is the loss of the concavity, which is typically seen in any radiograph for the diagnosis. Non-infectious spondylodiscitis or Anderson's lesions, which are seen as hemispherical signal alteration in the discovertebral area, which was also seen in multiple vertebrae in our case. Bamboo spine appearance, that is syndesmophytic ankylosis, because of which fractures occur, carrot stick fracture, typical carrot stick fractures occur, are also seen because of the ossification of the ligaments. Syndesmophytes are vertically oriented ossifications of the annulus fibrosus, which are seen in radiograph or CT very well. Linear and they can be differentiated from osteophytes because osteophytes are horizontally oriented, syndesmophytes are vertically oriented. Linear ossification along the central spine, interspinous ossification giving dagger spine, tram track sign, all these things are also very well seen on radiographs for the diagnosis of ankylosing spondylitis. Then along with that, pseudoarthrosis occurs when there is a carrot stick fracture of the spine and there is healing of the spine. Then dural ectasia is also a feature of ankylosing spondylitis, which was not seen in this particular case.